Good morning. Again, it's a pleasure and an honor to be here today. What I'm going to talk about is numeracy and some of the, coming off of Dr. Ginsburg's talk, some of the implications of numeracy within the Affordable Care Act. I'm not going to bother defining numeracy. Dr. Ginsburg, I thought, did an excellent job of doing that. What I'm going to talk about first instead is why might numeracy be important to the ACA, to the Affordable Care Act. And it's important because numbers are ubiquitous in health decisions, whether it's the number of pills somebody takes, what time of day to take those pills, choosing between different treatment options based on risks and benefits. Numbers instruct, they inform, they give meaning to information about health plans, medications, and treatments. But as we found out, and as many of you knew already, not all people are able to understand and use numbers effectively when making health decisions. And even highly educated people, even people with PhDs and masters and college degrees, that does not mean necessarily that they're numerate. Numeracy and education are related, but they're not synonymous with one another. People who are innumerate tend to understand less numeric information out in the world, as you might expect. But it's also not just about comprehension of numeric information. People who are less numerate also use numeric information, and they use non-numeric information in ways that are different from the more numerate. So numeracy influences comprehension, but it also influences the use of information. How information is presented can attenuate, can lessen these kinds of numeracy differences. And I think we're going to hear a lot about that today. What I'm going to do today is discuss the paper that was commissioned that I wrote with two of my colleagues, Louise Mayer and Mary Kate Tompkins. And I'll briefly discuss each of the sections. Other eminent researchers in the room, some of whom I've known for a long time, some of whom I've had the pleasure of reading and meeting today, are going to expand in their own ways on some of these sections. And so I'll give sort of an overview of the paper. The first question that we went to look at is, what does research show about people's numeracy skill levels? The first point is kind of obvious, particularly after Dr. Ginsburg's talk. Americans have limited numeracy skills, and disparities exist in those numeracy skills. People who are less numerate tend to be more likely to be female, to be older, to be less educated, and to have lower income. And some of these disparities are related to whether or not you currently have health insurance. And that ends up being important to the Affordable Care Act, because the people who are going to be entering the health system for the first time, maybe not for the first time, but who are going to have greater access to the health system are those people who currently do not have health insurance. What we did, there are many different ways to measure numeracy, and some of them are objective, some of them are subjective tests. I'm going to focus a little bit on what Dr. Ginsburg originally introduced, the assessment that comes out of the National Assessment of Health Literacy. And in that, they estimated the proportion of Americans who fell into 4 quantitative literacy performance levels. I am, by the way, going to use the term quantitative literacy and numeracy as the same term. I will probably accidentally throw in numeric literacy occasionally. To me, they all mean the same thing. I'm happy to talk about that if someone wants at some point. But I just wanted to point that out. Within the NAAL, they estimated, for example, and Dr. Ginsburg pointed this out before, that 22% of the American population falls into a below basic level of quantitative performance. And that means that 22% of the US population can do fairly simple number operations. They can locate numbers in a text. They can perform some simple kinds of quantitative operations like addition if they know what it is that if they're told that it's addition or it's really easy to infer from the situation. Another third of the people have those below basic skills, but on top of that, they have somewhat more advanced basic quantitative literacy skills. Another third of the people have intermediate skills. Again, they have the 2 levels of skills above them, but they also have a few more intermediate skills that allows them to locate less familiar quantitative information, for example. To use that information to solve problems where they're not necessarily given the arithmetic operation, or it's not easy to infer it from the situation. So they're just a little bit better at these kinds of numeric sorts of operations. Only 13% of the population is what we'd consider proficient in numeric literacy or quantitative literacy. I told you I was going to do that. And what that means is that 87% of the average US population can't solve problems like this. They can't calculate the yearly cost of life insurance using a table that gives the cost per month for each $1,000 of coverage. The people in this room, I would bet every one of you can do that kind of an operation. You fall probably within the 13% of the proficient population in terms of quantitative literacy. What we were interested in, though, was the idea that some of the numeracy differences are linked to whether people have health insurance or not. The NAAL provides quantitative literacy levels at the population level, and that's what I'm showing in that second column there. But they also provide quantitative literacy levels by education level. The US Census data provides data on very similar education levels, but they provide it by health insurance status. So we can look at that within people who currently have health insurance versus those who don't. And what we did is we took these two data sets and we made an estimate of what do we think the numeracy skill levels are going to be in the uninsured population. Now, I do have to tell you, the data sets don't line up perfectly. This is not a perfect estimate. What we wanted to do is just to sort of get an idea of the relative numeracy levels between those people who currently have health insurance and are most prevalent within our health system versus those people who do not currently have health insurance and they haven't experienced the health system as much, but they're going to through getting health insurance through the ACA. And this is what we found. And again, this is an imperfect estimate, but I wanted to give you guys an idea. What you see in green is the estimated proportion of uninsured adults. So these are people who will be eligible for health insurance for the most part under the ACA. And what you can see, if you take a look just at the proportion of people in that below basic level of quantitative literacy, a full 29% of the uninsured, we estimate, are going to fall in that below basic level of quantitative literacy. That means they're going to be able to hopefully be able to locate numbers in tables, for example, perform simple operations, but they're not going to have the skills to perform operations at the higher levels, at the basic, the intermediate, and the proficient levels. You can see other differences at the proficient level. People who are uninsured are going to be less likely to be able to fall into that proficient level of quantitative literacy. So as a result, numeracy issues are likely going to be more prevalent in this currently uninsured population who's suddenly going to have health insurance. And that's in comparison to the already insured population. What this means is that healthcare providers are going to be faced with a different population of patients and consumers. They're going to be faced with a less numerate population than before. And one question is, are they prepared? Because the communication concerns are different among people who are less numerate compared to people who are more numerate. In addition to that, numeracy issues may increase when people are in poor health. Being a patient may reduce deliberative capacity. It may reduce people's ability to think, in a sense, and about numbers in particular. And that's because they're sick. They don't feel well. I have a terrible cold right now. I hope I can answer your questions because I know they're going to be pointed. But I'm not thinking as well today. It may also reduce deliberative capacity because patients are stressed. They're under emotional stress, for example, oftentimes. They're often overwhelmed with the quantity of information that's being thrown at them because of treatment options or new tasks that they have to do that they didn't have to do before. We're often, as patients, under time pressure because you have to make a decision in the physician's office, for example, or you have to make a decision quickly for some other reason. According to dual process theories in judgment and decision making, and I'm a psychologist, by the way, I study basic psychological theory. According to dual process theories in judgment and decision making, what this means is that patient populations who are sick may understand and use numbers less well in decisions, and they may actually rely on emotional sources of information that are a little easier for them to process. They may rely on those more. Little research exists on this, though. But one question is, do current numeracy estimates, like from the NAAL, for example, is it possible that they overestimate the skills of patient populations when those patient populations happen to be sick? Dr. Terry Davis is going to talk a little bit more about this issue from a much more concrete perspective, as I understand, after this. The second question that we were asked to take a look at is what kinds of numeracy skills are needed to do a variety of different tasks within health. And what we did in our paper, and I'll talk about briefly today, we broke numeracy skills up into two different groups. The first group that we broke it up into comes actually from a paper by Dr. Andrea Apter. And we're going to loosely call those, we did loosely call those education-based numeracy skills. They're more about mathematical content and procedures. Excuse me. Within the education-based numeracy skills, Dr. Apter and her colleagues talked about a hierarchy of numeracy skills that are required to make health decisions. And within that hierarchy, the skills range from very basic, very easy kinds of tasks that people need to be able to do. And this is like, again, like locating information in a table, performing a simple addition kind of operation. For example, adding together premium costs or something like that. Other kinds of numeracy skills that are a little more difficult are computational skills, working with frequencies and probabilities, for example. Analytical skills are more difficult than that in this hierarchy of numeracy skills. Statistical skills, which are often required for understanding the inherent randomness of life and the inherent randomness of health decisions, are considered among the hardest of these skills in this hierarchy of skills. Dr. Apter is going to talk quite a bit more about this than I'm going to today because this is what she does. So I look forward to hearing her talk. What I'm going to talk about a little bit more are what, again, we sort of loosely termed emergent decision-based numeracy skills. This may be similar to what Dr. Ginsberg talked about in terms of productive disposition. I wasn't really quite sure about the distinction in what she was talking about, but I think it may be related to that productive disposition. In a previous AHRQ report by Berkman et al. From 2011, one of the things that they concluded was that having a theoretical basis to interventions made for more effective interventions to reduce health disparities. And so one of the things that we look at within the psychology of judgment and decision making, which is my field, we look at the idea that what numeracy might do is it might exert its influence on health decisions, and it's through the making of health decisions that numeracy may ultimately influence health outcomes. And so what we're looking at in terms of these emergent decision-based numeracy skills are psychological mechanisms that people have to go through in order to understand and use numbers. And so some of these may seem super basic, and yet there are differences based on numeracy. People who are highly numerate are actually more likely to seek out numeric information rather than avoiding it. So it's not just about putting information in front of people and seeing if they understand it. It's about, do they actually go and find the information? And then if the information is exactly in front of them, do they look at it? Because there's lots of information on a page a lot of the time. And it turns out that people who are highly numerate are more likely to zone in on that numeric information, where the people who are less numerate are more likely to look elsewhere, actually. People who are more numerate are also more likely to ignore that other irrelevant information or less relevant information on a page. People who are more numerate are more likely to recall numeric information. That's often done with some simple memory tests, but it's important because you have to remember how many pills to take. You have to remember what time to take them. There are a number of numeric kinds of information that you have to remember that can help to facilitate health decisions that you make or health behaviors that you take. People who are highly numerate tend to be more sensitive to different levels of numeric information, where the people who are less numerate tend to be more sensitive to non-numeric and often emotional sources of information, like what their friend told them about a treatment, or what they heard about from a neighbor about getting some screening option, for example. The highly numerate's ability to be more sensitive to numeric information may be due to a particular psychological mechanism. People who are highly numerate seem to derive more affective meaning from numeric information. And what this means is that they're better able to interpret numbers within the context that they're making the decision. They're better able to tell whether, not just that it's a 9, but whether how good or bad this 9% is for them within the context of the decision at hand. What research has shown is that if you don't have a feel for the goodness or badness of a number, you may know what the number is, but you don't know what it means, and you're less likely to use it in judgments and decisions. And so part of that greater sensitivity to numeric information that the highly numerate show may be due to their ability to derive meaning from numeric information and from comparisons of numbers. Each of these education-based and decision-based skills are required in at least some health decisions. And I thought I'd go through at least, I thought I'd have us look at least a couple of examples today during this short period. What I have in this table are 4 different columns. This is the quantitative literacy level that we estimated for the uninsured population. Thank you. This is an actual NAAL item. And this is a comparative item that we thought matched up pretty well to the NAAL item. And these are skill categories that we think may be needed in order to be able to successfully solve whatever the problem is. And so, for example, a below basic item, that's an example task within health plan selection, and it's a super easy task. All of you guys can do this. The task is to compare and calculate the difference between monthly premiums for two different health plans. We estimate that about 29% of the uninsured population should fall in this below basic level, and most patients, the below basic population, as well as populations who are at higher levels of proficiency, most people should be able to do this fairly simple task. Now, mind you, not everybody will be able to, because people who fall within this below basic category nonetheless vary quite a bit in their actual numeric abilities. And we've done other studies within health insurance choices that show that somewhere, in a particular study that we did, about 7 to 9% of people who range from 18 to 64 weren't even able to find very basic information in tables and charts. And so it's not that everybody is going to be able to do this task, but most should be able to. In fact, we did, in a paper that we did back in about 2007, I think, by Jessica Green was the first author. We had people looking at two different health insurance plans, one that was sort of a new concept for a health insurance plan, and one was a more traditional health plan. And what we asked them a number of comprehension questions, given information about these two different health insurance plans. And what we found was that most people understood which plan had the lowest monthly premium, but only about a third could identify which plan was better if the patient needed a lot of care. We estimated that harder task, we estimated to be at about an intermediate level of proficiency. Another example at an intermediate level of proficiency is understanding medication and treatment instructions. This is an item that comes directly from the NAAL. A patient forgot to take medication and needs to figure out what's the earliest time that he can take it in the afternoon. And they're given information about what time they last ate and the instructions on the medication bottle. Within this intermediate quantitative literacy level, we estimate that about 29% of the uninsured population will be here. About 62% of the uninsured population likely will not be able to answer this item correctly, according to the estimates that we did. They won't be able to figure out, how should I adjust my medication now that I've forgotten to take it? At the proficient level of quantitative literacy, we estimate that about 9% of the uninsured will be at this proficient level. What this means is that 91% of the uninsured population will not be able to do the kinds of tasks that we would consider proficient. And some of the things within, for example, diabetes management or management of other kinds of chronic diseases likely require, to be able to do it very effectively, likely require some of these proficient kinds of skills. The last question that we looked at, and I'm only going to go through it briefly, is how can providers communicate with those with lower numeracy skills? Estimates for what proportion of the uninsured population will be able to correctly do different kinds of tasks, in the end, will ultimately depend on how that information is presented. Just as individuals range in their numeracy, health materials, in a sense, do too. Health materials can require greater numeric literacy to get through or less numeric literacy to get through. I'm going to go through a brief summary due to time constraints today, but I'm going to look forward to hearing from many of our other speakers about some of these issues. Just to briefly summarize some of the recommended strategies for communicating with the less numerate. The first might be a little surprising. It's to provide numeric information as opposed to not providing it, because numbers matter. They inform. They educate, they give meaning to information. People who are less numerate, of course, are less good at dealing with those numbers, and so paying careful attention to information presentation is critical, particularly among these less numerate populations. And some of the other recommended strategies get at how should we be providing information. One of the biggies is to reduce the cognitive effort that's required. This gets at a lot of those education-based numeracy skills that Dr. Apter will talk about further. But there are a variety of different techniques that can be used to reduce that cognitive effort and allow people who are less numerate to better understand and to use the important health information, numeric information that we want them to use. If information is unfamiliar, people don't have a context for understanding its meaning, we can provide evaluative meaning through consumer report symbols or through interpretive labels. And this is particularly helpful for the less numerate when numeric information is unfamiliar. People who are less numerate are less likely to attend to numeric information even when it's provided. But there are techniques that you can use to draw attention to important numeric information. We can also set up appropriate systems to assist consumers and patients. One of the most important parts of these appropriate systems is to figure out what's the goal of my communication. And then once you know what the goal of that communication is, what should it accomplish? Okay, how can I go about using the evidence basis for how to best communicate to the less numerate in order to meet the goal of that communication? All diabetics should probably receive an honorary degree in mathematics, but that may be true for all patients as well as health communicators as well. Health decisions involve and health behaviors involve a lot of numeric information, either explicitly or implicitly. Just in conclusion, average numeracy skills in the ACA population are likely to be lower. We've gone through at least that rough estimate of the currently uninsured consumers. It's also important to note that they have limited knowledge and experience, more limited knowledge and experience in health settings. How information is presented may matter as much as what information is presented, particularly to these less numerate populations who aren't as good with numbers. And then finally, communications should be evidence-based. There is an evidence basis for communication, and it should be used. With this new population, particularly with their lack of experience in health settings, when possible, communications should probably be tested at least early on in this population as well. Thank you.